Hi, I'm Dr. Kuhn from Providence Clinic, and today I want to tell you about how things work in our office, what kind of care we give, what kind of decisions we make on whether we accept a patient or not, and basically how the whole process works. Now, to start off with a brief explanation, the short version of what we try and do when you come into the office is we try and put your head on straight. We adjust right up at the top of your neck. It's the very top bone in your neck. It's called the atlas bone. We adjust at that level for two big reasons. One is that the atlas bone is your most likely bone to become injured in your spine, and that's because it's the least reinforced. Every other bone up and down your spine, your atlas bone sits right up top here. Every other bone right up and down your spine has a big chunk up front called the vertebral body. That's held to the ones above and below by the discs and ligaments in between. And then at the back, you've got interlocking and overlapping facets or joints going up and down each side. So there's a very limited amount any of those bones are able to move before they hit pretty solid reinforcements that help stop them and pull them back into place. Now, your atlas bone is unique because it doesn't have any of those features. It's a ring of bone that looks like this one. It sits right up under your skull, kind of there, and it pivots on a piece that comes up from the bone below, which is called your axis. And it's called that because it's the axis of rotation. Your atlas sits on top of that, and it pivots on that bone and is able to move actually quite freely. So there's a lot of rotation and movement and action that can happen up at that level as compared to anywhere else in your spine. Now, the other reason we focus on adjusting in that area is that it's also the most important bone in terms of position, which makes sense because your brain is up here and the rest of you is down below, and your atlas is the door right between the two. Now, on top of that, we know it's the most important bone because there's evidence of it. They've done studies where they've done tissue studies of the body, and what they've found is that there's a higher density of proprioceptive or position sensing nerve fibers in the muscles that connect directly to your atlas bone than you have anywhere else by a factor of at least 5. So that means that when that top bone in your neck starts to shift a little from where it should be, your brain starts getting a lot of information telling it that it's not where it's supposed to be and to make sure it doesn't get any worse. Now, when that happens, we run into a little bit of a problem. See, you don't have any muscles in your spine that are able to move just one bone. I can hold my shoulders still and I can turn my head fine, but I can't hold any one bone in my neck still or anywhere else in my spine and just move the one beside it. And so when that atlas slips from its position, you've got no muscles in your spine that are able to pull it back into place. And you also don't have any of the reinforcements up at that area that can help it get there by itself like you have anywhere else. And so what happens when it does slip from its position that it should be in is your brain gets all that input from those proprioceptive fibers telling it that that's bad and it doesn't want it there and it doesn't want it to get any worse in particular. But you're not able to fix it. And so you just lock everything down and tighten up through all the neck to keep that bone from moving any further from where it should be. Now, that tension creates a lot of stress on the head and neck and down into your shoulders. It creates a lot of strain in that area. And what ends up happening when people do that is they start to tighten up their neck to hold their head, keep their atlas straight, or it could keep their atlas from getting any worse. And that starts to straighten out the neck so that you can't keep a normal curve in your spine with your head back and your neck curving forward like you're supposed to have. What ends up happening is your neck stacks up and straightens out. You end up staring at the floor. Nobody wants to stare at the floor forever. And from here, what people end up doing is they shift how they sit and stand so they can get their eyes back to the horizon. Now, on top of this position, patients also find that they tilt their head slightly or have it turned compared to the atlas. And so from here, people want to get their eyes back to level, get their head back to balanced, and then minimize the rest of the stress on the spine. And you'll notice my whole posture ends up falling apart because that bone has moved a degree or two from where it should be. We don't usually deal with a lot of misalignment at the atlas. A couple degrees is typically all we'll ever see. And we don't end up dealing with big misalignments there because big misalignments in your upper neck tend to kill people. There are too many important things that go through a very small area up there to mess with it very much. Now, because we're dealing with such small misalignments in the neck, I don't just feel your neck and guess whether it's out one way or the other because it's not very reliable. What we do instead is we look for all the postural breakdowns that happen because you've got a misalignment, And that shows up in a couple different ways. We check the legs when people lay on their back. Their legs should hang nice and level and even if they're where they're supposed to be. When a patient is out of alignment, they're torqued and twisted and bent and crooked, and that's torqued their whole body all the way down. So their hips are out of alignment as well. And so when they lay on their back, one leg is pulled up and looks short compared to the other one. Now it is possible to get a physically short leg. The only cases we tend to see of people who have a physically short leg are people who've had hip or knee replacement surgeries where they haven't done them the same length, people who've had major breaks or injuries that haven't healed properly, and then any patients who've had a history of polio or something where the leg didn't develop all the way. Everyone else we see starts off crooked in terms of those legs. As soon as we get their alignment corrected up here, all those muscles tend to relax, their body comes back to balance, and those legs will level right out. Now the other measurements we check is we measure posture. We stand patients up, we measure where their hips are to find out if you're level and the hips are crooked. We measure the whole posture overall using digital systems where it captures a picture of your posture and the computer analyzes it, which gives us a good idea of like, okay, are you within the normal limits of where you should be, or are you compensating and twisted? The other nice thing with the equipment we use is that it tends to give people a picture they can look at, and when we track over time how you recover, we can see improvements in that. The last set of measurements that we check when we have patients come into the office is we check for any changes in the cervical range of motion or how you move your head and neck. Now with that, we look at how far you can move in all the given directions, find out if you can move as far as you're supposed to be able to, and then we also look at how you get there, because some people can move the right number of degrees, but they'll cheat in how they get there. And they'll cheat by, let's say they can turn their head to the left with no problems, but when they go to turn their head to the right, something gets stuck at one point, and rather than jamming up and stopping, your body wants to get to the same number, so it just cheats and gets around it. And so we'll see differences in how people move one way versus the other when there's something going on. We're able to catch that digitally as well so that patients can actually see what's happening when they move their head. Now those three measurements all tend to agree. They tell us whether or not you have something going on we can help with. Now if you do have something going on we can help with, the only way to find out what's happening up here and how to address it is we shoot x-rays of your head and neck. We are very particular on the x-rays we shoot because we are measuring very small movements of that bone. So we currently have a two-dimensional digital system in our office that we're using. We're looking to go to three-dimensional in the future. With the two-dimensionals, we have head clamps and laser beams and all kinds of things to help make sure we keep you exactly lined up when we're taking the picture. It doesn't hurt. It's extremely low dose and exposure ratings for x-ray, and so they're super safe to do. But those give us the picture in all three dimensions of what's happening up in the upper neck, and so we can figure out how to address it. Now based off those x-rays, we look at where you're at in all three dimensions. We check the position of the lower neck, your atlas, and your skull. We look at the angles involved in all the joints in there, and we do a bunch of math with that information to figure out how to be the muscle that you don't have. Now the adjusting style we use when we adjust you is called NUCCA, which you'll see right on the sign there. And NUCCA stands for the National Upper Cervical Chiropractic Association. It is a group that has worked on developing a system of analyzing and correcting the neck that is effective, reproducible, and as minimally invasive as possible. And so the adjustment itself is horribly unimpressive. It's not like what most people would expect from chiropractic care. There's no jumping up and down on patients or sudden twists or movements. There's nothing in the table that drops away. Patients will lie on their table in a very low solid table and their head will be brought right to neutral. And then the adjustment itself is going to feel like the weight of the doctor's hand about on the side of your neck. So there's no jumping up and down or any of the things that you would normally think of or that people often worry about with chiropractic care. Now, if we do a good job with that and we figured out the appropriate angle to come at it from, we're giving your body exactly what it wishes it had to get to exactly where it would like to be. And when we do that, it allows things to start to move back towards balance, and we see immediate changes because we've now changed that input in the neurology. And so we'll see the legs level out right away and patients start to relax on the table immediately right after that first adjustment. The other thing we'll do right after your first adjustment is if we see those changes start to happen, we know we've got something moving the right way. Now once we got that, we do a post set of x-rays after your first adjustment so we can evaluate if we got the kind of correction we were looking for, or if we need to change or tweak anything we're doing. Now, in some cases, we knock it right out of the park. People look nice and straight and balanced on their post x-rays. That's fantastic. It means we did a good job. It means you read the textbook. High fives all around. If we don't see that, we try and figure out what's going on and why, and then what we need to adapt or change for your particular case in order to make sure we get a better correction. Now, in some cases, there's patients who've been stuck like this for decades, and it takes a while for some of those body shifts to unravel. And so it may take a while for some of the angles in the neck that are being driven by those lower factors to come around. And in those cases, we just have to wait. In some cases, there's more resistance in one part or another of the misalignment, and we need to tweak where we're coming at it or how we're adjusting in order to get a better correction. And then in some cases, patients haven't read the textbook. And so they'll often have asymmetries and anatomical abnormalities where 0, as far as what the textbook says is 0, isn't 0 for that patient because they aren't built with textbook parts. In those cases, we see that a lot, and we are able to figure out where 0 looks like it is for you so that we can get things moving back in the right direction and make sure we're getting the most appropriate correction for your particular case. So our care is really the same for everybody, but it's also tailored very specifically for each individual person. Now, once we've got a good correction there on that first adjustment, we've essentially dialed in and figured out the key for the lock, so to speak, that we can use to put you from where you're injured back to where you're supposed to be. When we've done that, we've essentially unsprained your neck. Now, like any sprain, it's going to take time to heal. And so we do checkups over about 8 weeks to make sure patients stay put while they're healing. Now, you're most likely to slip in the early stages, and we also don't really know if we've got you stable right off the bat. So we do 2 checkups in that first week, then we do once a week for the next 3 weeks after that, measure your posture at that 4-week mark, and then we do a checkup at 6 weeks and 8 weeks, and at 8 weeks we remeasure your posture again. We spread them out as you get on in the 8 weeks because by the 8-week point, you're usually doing well. You can typically, you're a lot more stable. The sprain has had time to heal. Now, with that 4-week and 8-week mark, where we remeasure the posture, we should see an improvement in your posture getting more straighter and better. However, it's unlikely that we see patients have a perfect posture by the end of 8 weeks. Your body takes about a month for every year that there has been an injury to recover to as good as it can possibly get, and most people have had injuries longer than they've had symptoms. So there's a very good chance with most patients we take care of that they'll have months to years worth of working out all the kinks and straightening right out. Now, the good news is that we don't have to see them very often during that time. If we get this alignment stable and holding, our patients hold very well, and on average we only see them a couple times a year once we get them lined up through that 8 weeks. The other good news is it doesn't take a month for every year that there's been an injury to recover to as straight as, to recover in terms of symptoms and what patients complain of when they come in. And symptom-wise, we see all kinds of things come in and all kinds of things get better. We are not a one-stop cure-all shop, but the underlying injury that happens up here that causes all kinds of adaptations in the body can be an aggravator or a cause of a lot of different issues in a lot of different parts of the body, from migraines, seizures, chronic fatigue, epilepsy, down to arm and upper back pain, lower back pain, sciatic issues. We've seen all kinds of things come through the office, and the vast majority of them seem to improve. Now, like I said, it doesn't take a month for every year you've been injured to actually feel better. The vast majority of patients we see will start to see improvements in their symptoms within the first week to 2 weeks. So in the first week, what we'll often see is that patients will have a corrective movement of their posture. And as that's happening, you may have been stuck like this for a long time. And so about half the patients we take care of will get some aches and pains as their body tries to straighten out in those first day or two. It typically feels like a good workout. It's not usually very bad, and it recovers the same way a workout would. You just rest, you use a hot shower, you do a little bit of stretching, and things should settle right down pretty quickly. The very rare patient we take care of will feel like we've been run over with a bus. And that's often because when we correct the misalignment, we don't control how fast your body tries to straighten out. If it does all of that movement right away and quickly, it may be like doing a really big workout. Now, once we get through that first stage, the first week can have some ups and downs in it because a lot of postural transitions are going to be happening in that time. And when that happens, you end up moving things you haven't moved in a while. You may have to work past some things that are a little touchy or inflamed, or you may work past some adaptations you've made around old injuries. So a lot of patients we take care of will have aches and pains that can flare up over a couple days to a week as things kind of work themselves out. They tend to be very short-lived if they do get sore, and by the end of that first week, most of that heavy lifting is done, and then the inflammation is allowed to start settling down. Now, by that point in that second week is when most patients can notice things are improving or getting better. And then by the 2 to 4 week mark, your soft tissues are actually starting to heal and solidify in the right position. By that point, more than 90% of the patients we take care of are seeing significant to complete improvements in most of the major complaints they came in with. Now, by that 4 week mark, like I said, we remeasure your posture. You're usually pretty stable at that point. And so at the 6 week and 8 week point, it's generally just people improving and getting better continually. We can't control how fast you get better because we don't know what kind of injury you've got, how substantial it is, but we can get rid of the underlying irritant or cause of it and allow that to heal the way it should. Like I said, by 8 weeks, generally people are doing really well. At that point, you can usually tell when you're in and out of alignment. And so at that point, we just kind of people call us and come in when they feel like they need to, or we do call-outs at about every 4 to 8 months to get people in to check up and line them up, because that's about the average of how long our patients hold. Now, even during that first 8 weeks, your checkup visits are literally checkup visits. We're not adjusting you every single time because then that defeats the purpose. That means we haven't done a good job. And so what we want to get you to is where you're stable and holding. And so the majority of our patients do hold their first adjustment quite well. And on average, we'll only have to readjust somebody once, maybe twice during that 8 weeks. Now, if we do have to adjust somebody, we don't have to shoot x-rays on them every time. Your old injury is always, going back into that is always the path of least resistance. Even once you've fully healed, scar tissue never gets as strong as uninjured tissue. So once we've figured out how to correct somebody from where they're injured, if you're going to re-injure, you're always going to tend back into that same old position, which means we can put you right back on track with the same numbers we calculated at the beginning, and we don't need x-rays every single time, which is fantastic. It means less work for us. It means people get to respond and get better way easier. Now, there are cases where we have to reshoot x-rays. In rare cases, somebody just won't stabilize the way we think they should, and we'll reshoot some x-rays to find out why and try and nail it down and track down what might be missing in terms of getting them stable. If we do that, in our office, we never charge for those follow-up x-rays to figure things out. We want to get you lined up so you can go heal and we can do less work in the long run. Now, when you are on the hook for a new set of x-rays is when something changes your misalignment, and that doesn't often happen from normal day-to-day stuff. If you bang your head getting into the car or on a low-hanging beam, or you slip and fall on the ice, those are going to often put you out of alignment, but they won't create new injuries. New injuries tend to come from car accidents and surgeries is the biggest reasons we see them. Now, with car accidents, it's obvious 2,000-pound bullets don't play nice. When they collide and you get an impact, even at low speeds, there's a ton of force involved there, and the rest of your body is strapped into the vehicle while your head is not. And so what you end up with is this 15-pound bowling ball you've got up on your neck trying to fly around the car but being held by your seatbelt and then the rest of your body, which creates a tremendous force at that area and can create new injuries even at fender bender levels. Now, the surgeries, and the reason we see new injuries happen that way, is not necessarily due to being under the knife. It's due to the general anesthetic that people get put under when they're going in for surgery. General anesthetic turns you into a jellyfish, and your atlas is primarily held up here by muscles. So when they knock you out and then intubate, position you, move you, do whatever they have to do to get you back to balance or correct whatever they're doing, what ends up happening is there's no brakes on the system at that point. And so anything can shift in any direction. So those are the two cases we'll most often see people re-injure in new ways, where we'd have to kind of reshoot x-rays and restart the process with them. Otherwise, the vast majority of patients we take care of will maintain their alignment, and then if they do lose it, go the same way as their original misalignment and do that over decades. And so it tends to be very effective, and we tend to get people lined up so you get to go live life and not spend it all in our office. I think that covers most of the basics. If you have any questions about it, throw a comment down below so we can hear about it, and I'll address them in future videos. Till then, my name is Dr. Ben Kuhn. Appreciate your time and have a great one.